Hi, welcome to Plasma. So we are going to discuss fracture of lower end of radius, Colles'S fracture. We'll first learn related anatomy. This is the palmar surface, dorsal surface, distal end and proximal end. This is radius, ulna, the carpal bones, which will form radiocarpal joint with radius. The radius at its distal end articulates with ulna at ulnar notch here and articular surfaces of scaphoid and lunate bones. So this is a dorsal view of hand and wrist where you will be able to appreciate radius, ulna and the carpal bones in the proximal row, scaphoid, lunate, triquetral and pisiform. In the distal row, trapezium, trapezoid, capitate and hamate. Now when you will see wrist and hand AP view radiograph, then you will be able to appreciate pisiform shadow which is superimposed on that of triquetral, and hook of hamate appears as an oval whitening. Trapezium and trapezoid slightly will overlap each other. Similarly, this is palmar view. Try to appreciate the bones. Okay. Now coming to Colles fracture. So it is not that common, but it is the most common fracture in persons over 40 years of age, and especially in women. The association of the fracture with osteoporosis is now well established, and it is frequently the first indication of presence of generalized loss of bone mass. It is also associated with fragility fractures, right? Now, the fracture is always caused by a fall onto the outstretched hand. Now, in few cases, there will be simply a crack without displacement, but generally, in majority of the cases, you will see fracture and displacement both, right? And the fracture occurs transversely about 2 centimeter above the lower articular surface of the radius. Okay. See, the distal fragments of the radius is tilted backward so that articular surface is directed downwards and backwards instead of downwards and slightly forwards as in normal state. Normal state here this is shown, and it is depicted. The normal state is shown for comparison with level of fracture indicated by interrupted lines. Right. Now we'll see a typical Colles radiograph. Now this is lateral view. You can note the backward displacement and backward tilt of the lower fragment, whose articular surface now points downwards and backwards. Now in this case the styloid process of ulna is intact, okay, and but commonly it is fractured near its base. Now there is a particular deformity associated with Colles fracture, and its name is Dinofolk deformity. Okay, so you can see this is Dinofolk deformity. Now what happens is there is dorsal hollow or depression in the lowest third of the forearm here, proximal to the fracture, but immediately below there is marked prominence caused by lower fragments being displaced backwards, carrying with the whole of the carpus and the hand. Anteriorly there will be fullness where the soft tissues are stretched over the forward projecting upper fragment, right? Now there is one more thing called reverse deformity, that will be Smith's fracture. We'll discuss it in some other video. Now the next thing, treatment options. So in displaced fractures, the standard method of treatment is to undertake manipulative reduction, right? It can be given under either local or generalized anesthesia, or you can immobilize the forearm and wrist in a below elbow plaster. And there should be one more one. This is the most important point, that while reducing the fragments must be first disimpacted and bone drawn out to full length, right? The distal fragment can then be repositioned accurately by firm pressure over the dorsal surface. So the technique of reduction would be, the muscles of the forearm should be relaxed either by general anesthesia or supplemented by a relaxant or by regional anesthesia. The first step to disimpact the fragments which have been driven together firmly in position of deformity. Okay, so this disimpaction is usually achieved by uh, firm longitudinal traction upon the hand and thumb, right? Now this image you can see, this is the first step in the reduction of fracture of the lower end of the radius. With backward tilting of the distal fragment, traction is being applied to disimpact the fragments. So first step in the reduction, where traction is being applied to disimpact the fragments, right? Now see one more image where this is the thenar grip, right? This is called thenar grip. Now it is recommended for correcting the backward displacement and tilting of the distal fragment of the radius. Now you can note the position of the surgeon's hands. The thenar eminence of one hand is placed over the distal fragment to press it forwards against a counter pressure of the other thenar eminence upon the shaft of the radius just above the fracture. It will be found easiest to use the right hand to control the distal fragment when the fracture involves the left radius and left hand in a fracture of the right radius. Now when the fragments have been disimpacted, their mobility can be demonstrated by grasping the distal fragment between finger and thumb of one hand and the proximal fragment likewise with the other hand. Now this image is dorsal plaster slab. Now this is a usual method of immobilization for fracture of the lower end of radius. This slab covers the dorsum and slides of forearm and wrist. It is secured firmly in position with cotton bandage. Fingers and thumb must be left free so that hand may be used. Right? You can see the fingers and thumb are left free. Now in plaster also there are two variations possible. So there is one that is the dorsal plaster slab and the complete encircling plaster. So this image you can appreciate. This is the dorsal plaster slab, right? Usual method of immobilization for fracture of the lower end of radius. This slab covers the dorsum and slides of the forearm and wrist. It is secured firmly in position with cotton bandage. Fingers and thumb again left free, right? Again we'll talk about this fracture. Plaster used alternatively for fracture of lower end of radius. This wrist is neutral position. Plaster is molded closely to grip the lower fragment. The palm is left free beyond proximal transverse skin crease to allow full flexion of metacarpopharyngeal joint. Okay. Now in this radiograph, I think this is the radiograph after manipulative reduction, if I'm not wrong. Wait, let's see. Yeah. So the fracture seen to plaster after manipulative reduction, normal alignment is restored. You can see the normal alignment being restored. Now in the lateral radiograph, articular surface of the radius is directed downwards and slightly forwards. Now this is the normal orientation, right? So radius is directed downwards and slightly forwards. That is the normal orientation. Next radiograph you can see, I think this is this would be external fixation for unstable Colles'S fracture after reduction and wire fixation, right? So this is another way uh, to treat fracture. This is operative method. Now we'll talk about the complications. So first is malunion, right? And second is subluxation of inferior radio-ulnar joint. Third is compression of median nerve. Fourth is stiffness of fingers or shoulder. Fifth is reflex sympathetic dystrophy, that is Sudeck's post-traumatic osteodystrophy, right? Now we'll see a radiograph of subluxation of the inferior radio-ulnar joint after fracture of the lower end of radius. Now there was pain over the joint, the head of ulna was prominent and rotation of forearm was improved. After excision of the lower end of the ulna, this is the radiograph. Okay. Now this condition is the rupture of the extensor pollicis longus. Okay. The fracture of the lower end of the radius is not necessarily severe. Indeed, the tendon seems to rupture more often than after a minor crack fracture and after a major fracture with marked displacement suggesting vascular impairment in the crease. Clinical features would be usual interval between fracture of the radius and rupture of tendon is 4 to 8 weeks. Okay. And there will be inability to extend thumb, difficulty in using thumb. And there would be compression of median nerve, other complications, stiffness of fingers, reflex sympathetic diastrophy, that is Sudex post-traumatic osteodiastrophy. So, wherein the hand and fingers become markedly swollen, so that overlying skin is stretched and glossy, and joints become stiff. So, these are the complications you can read, right? Malunion, subluxation of inferior radioulnar joint, compression of median nerve, stiffness of fingers or shoulder, reflex sympathetic dystrophy, that is Sudex post-traumatic osteodystrophy. Thank you very much.